Okay, so let's carry on with giant cell tumors. Michael, what do you think of this?
Okay, so we see a kind of a well-defined lytic lesion involving the tibia, which involves both the metaphysis and the epiphysis, with thin sclerotic borders. And so on MRI, we see a lesion in that region, which is, it looks like, I think those are like fluid levels, like multiple small kind of pockets of fluid levels. There's kind of a thin, irregular, but with somewhat intact, hypointense cortex around it. Not much adjacent marrow edema. Yeah, and I guess that's pointing to the fluid level. So I think it's a giant cell tumor with secondary aneurysmal bone cyst formation, or is it just giant cell?
No, it's just a giant cell. Okay. If it really gets prominent, then you can call it an associated aneurysmal bone cyst, but this is pretty typical of just a giant cell tumor.
So they'll have to keratosis or
Yeah, rarely these can metastasize to the lungs. Usually it's a local resection for these. Okay. Ashley, what do you think of this one?
Here you see a well-defined lytic lesion involving the distal ulna with, I think, it's pretty expansile. I think the cortex is intact. I'd like to get some three-dimensional imaging here. Okay, yeah, it looks like the cortex is intact. It's pretty expansile. I mean, it's another giant cell tumor, I'm guessing.
Yeah,
looks pretty well defined. Yeah.
But you can't really make the diagnosis of giant cell just on these. There are a number of different malignant lesions that can produce these bubbly expansile type lesions rather than aneurysmal bone cyst. So this is you can suggest it, but again, this is a tissue diagnosis, not a tumor diagnosis. Good. Yeah. Okay. So here's the case. The patient first presented on 8/20. So somebody is John. Are you pressing down on something because we're getting beeping in the background? John and Ashu, could you both of you maybe silence on your end? We're getting.
Yeah, I'm silent. I can leave. Maybe.
No.
I don't know.
Can you hear that beep in the background? Oh, good. That stopped. Good. Whoever did it, thank you. So here's the case: 27-year-old female, 2008. It looks like a relatively negative AP radiograph. Maybe there's some stuff here, but prospectively, I don't think that was seen. And this now is just about 5 months later, or 7 months later, and this is what we see. So we go from a relatively normal X-ray to here we can see a large expansile destructive mass, which has destroyed the cortex with this large soft tissue mass adjacent to it. And the MR examination we can see here is this big mass, probably most likely bone neoplasm extending through the cortex with a fracture of the cortex into the soft tissues and some areas of necrosis centrally, which you can see there. And there we can see also on the axial images. If we go to CT scan, we can see some metastases in the lung fields. And this was also a giant cell tumor. This is a more aggressive form of giant cell tumor with pulmonary metastases. They still have a better prognosis than other metastatic type lesions. Yeah. Okay, Michael. Normal or abnormal?
Yes, abnormal. So there's just, the left, there's complete whiteout of the left hemithorax with displacement of the mediastinal structures to the right. At this point, you don't know what it is. Okay, so CT imaging, we see this large heterogeneous mass with maybe kind of all these kind of low density. I don't know if it's fluid signal, but stippled throughout. And then there's, complete collapse of the left lower lobe and large pulmonary effusion. Okay, so now MRI of the chest, we see this large mass with, numerable kind of like septated cystic structures. So this also looks like it has fluid levels. And I assume can we go back to the CT? Is this involving like a rib? Yeah, so that rib up there is destructive. So I mean, it's just this like a giant cell tumor in the chest then?
Yeah, so this is a giant cell tumor with head. This one you could call an aneurysmal bone, secondary aneurysmal bone cyst, but this also affected the vessels and the airways, which produced collapse of the lung. Okay, Ashley, what do you think of this one?
A 56-year-old female with history of treatment for giant cell tumor 30 years ago. We see kind of mixed lytic sclerotic lesion in the distal femur, mostly lytic. Here on the MRI, we see that it's a pretty heterogeneous lesion. It is bounded well by the cortex. I don't see a soft tissue component. There might be some central necrosis. Looks like it's very, it lights up on the bone scan, and there's some synovial thickening there. I don't know if that's part of the tumor or if that's just synovial thickening.
So what do you think this is?
I mean, I guess it could be recurrence, because local recurrence occurs a lot. So.
Well, they thought it might be recurrence, but the pathology showed an undifferentiated sarcoma. So this is a case where the patient was treated, and the patient a tumor came back, but it was a much more aggressive sarcoma and a different pathology than the aneurysmal bone cyst. I assume they had radiation treatment here. Okay, let's go on to the next category of notochord type tumors. Here's a 62-year-old female with sacrococcygeal pain for 4 years.
Okay. For how many years? 4 years. Okay. So on the MRI images, we see this fairly well circumscribed, lobulated, predominantly homogeneous, kind of intermediate to low signal. It's kind of similar signal to the adjacent muscle. It looks like it's involving the kind of central sacrum and extending. Yeah, it's within the sacrum itself. Fluid sensitive. Is this contrast or? Yeah, so it's got pretty diffused enhancement throughout the entirety of the mass arising from it. So at this, differential at this area, I'm thinking of something like a chordoma. I think they occur at the sacrum and in the cervical spine.
Okay, let's go on to some vascular tumors. Ashley, what do you think of this case?
I'm thinking we're looking at the vertebral body here, and it has a kind of a speckled appearance. So we're thinking hemangioma, I'm guessing.
Okay, here's a little thing. We don't really see the posterior cortex very well here.
Mm-hmm.
It's a little bit of speculation around the edges. So they got an MR scan, and this is what the MR scan shows.
Well, it's I don't know. It looks like it's pretty aggressive. There's a lot of posterior involvement. It's going into the spinal cord. It looks pretty aggressive. And it does have an enhancing component there, soft tissues, and there's some displacement. It's just aggressive hemangioma. Okay.
It's an aggressive hemangioma. Histology was benign.
Have you seen this yourself?
This is one that we had. Yes.
That we did.
I don't really have any smooth muscle tumors to show you. Go to lipogenic tumors.
Okay, so in the first image, palpable mass, the axial, we see. Trying to look. So we see this kind of curvilinear bone density and posterior to that, we see this area of curvilinear fat. So it's kind of a mixed dense bony and fat mass, which just appears to be arising from the cortex. And on we can see the fat saturate in and out, so we know it's fatty by this ANA-CT. It looks pretty well circumscribed, and the adjacent soft tissues don't look that involved. I'm not really sure what has like bony and fat within it. Yeah. I mean, you think of like normal lipomas, liposarcomas. It
has bone with it.
Yeah.
I don't really see any soft tissue masses except for
the fat part.
The fat part. It's associated with periosteum. And this is a
I haven't heard of that.
Okay, issue.
A 66-year-old female with dull pain in the knee for several months. Looking at the lateral aspect of the distal femur, we can see a lucent lesion with increased focal sclerosis within that lucency. It's pretty dense there. I'd like to get some. Okay, so it looks like this is a pretty well demarcated, some fat-containing lesion within the femur. Along the inferior aspect of that, and then there's maybe some necrosis more superiorly, or some fluid changes there. So, some type of liposclerosing or.
Okay, yeah, this is an intraosseous lipoma. I think you'd have to be concerned in this location about possibly a liposarcoma, but this was a benign lesion. Here's someone who had vague ankle pain, and here on the MR we can see that also there's an expansile lesion within the calcaneus with a central focus of necrosis, but fat around the area of necrosis, and the character is a little bit different from the fat within the remainder of the bone, primarily because you don't have trabecular bone in this fat, and that's why it's brighter on the T1. We can see that it darkens on the fat suppressed sequences, and that this is really around the neck of the calcaneus, and this is a cystic interosseous lipoma. And this is one of the most common locations for this particular lesion. And sometimes in teenagers, you're concerned that if they have pain, that could be due to fractures into this, or whether this could lead to increased risk for fractures. But I've seen a number of these, and so far I have yet to see one that's associated with a fracture, though I'm always kind of concerned about it when I see it.
One that looked exactly like that. 21-year-old male, dull pain, left hip for 2 months. Pain onset after physical activity such as swimming. So we have this lytic lesion with somewhat maybe kind of scalloped margins involving that intertrochanteric and subtrochanteric region of the left femur. I don't think there's any cortical disruption, at least not based on that. So on MRI, we see this kind of heterogeneous circumscribed lobulated lesion in that trochanteric region. Again, the cortex looks intact. And I'm trying to think. It doesn't really look, we're not still on, it's not really fatty tissues within there. Like there's maybe some fat, but like when you look on the T1s, they're intermediate signal. Is this that, got it. Is this that liposclerosing?
Yeah, well, that was my first thought. I think this is kind of a category
of that myxopibromas.
The pathologist in this case called this an interosseous lipoma, but my guess is myxofibrous myxofibrous lesion, and but that's a very common location for it. Yeah, I'm not sure about the different stages. Okay, this is a more traditional look to this particular lesion. Ashley, what do you think of this?
Well, this is well-defined lytic lesion with a very dense sclerotic border within the intratrochanteric line. I mean, it's typical liposclerosing myxofibrous tumor on X-ray, and it has similar features, yeah, on the MR.
Right. A typical benign lesion. And here you can guess that it's probably benign. If this were an aggressive lesion, you wouldn't expect the bone to be able to create this kind of a sclerotic focus. It would kind of blow through it. But that's a classic liposclerosing myxofibrous tumor. Okay.
I think maybe on the other one, the pathologist or whatever slices he had were just very liphomatous and just called it that.
You know, I think there are a lot of variations. I also think that now much more is becoming known of tumors, and our typical names for tumors and grading system for tumors, I'm sure is going to be phased out over the next few years. I think what we're finding is that a lot of different tumors from a biochemical and a genetic standpoint are lumped into a single name right now. And in reality, they all need to be more specifically evaluated. And I think treatment protocols are going to be specific to the genetics rather than the names we use them for them right now. So my guess over the next couple of decades, the entire way we categorize tumors is going to change as we have better understanding of the complexity of the genetics involved in tumors. And hopefully that will lead to much more better outcomes from more specific treatment based upon the underlying biochemical abnormalities that cause them.
Do you think that will result from? Do you think that that'll also result in more nuclear medicine, medical, specific biouptake scans to differentiate between these, or is it all just going to be pathology, histology?
Maybe the different nuclear medicine agents haven't really become. I mean, there are a few cases where they can be somewhat helpful, and so a lot of people are developing techniques along those lines. And there have been a few successes, but not many. It was a while in the early days of MR. What really drove MR in the early days wasn't the imaging; it was the concept that we could actually image biochemistry and look and actually quantify the amount of different chemicals in tissue non-invasively and do what's called the non-invasive biopsy. And that never took off very well, I think in large part because we just didn't have sophisticated enough techniques to really be able to evaluate the spectroscopy images. And I think as we go forward, people may well develop more aggressive, more robust algorithms that can do that. And so maybe eventually we'll be able to do that non-invasive biopsy by MR, but we're certainly nowhere close to being there right now.
In pathology, they do chemical studies.
Yeah.
And some lesions.
They do chemical studies. That they also do antibody studies.
Yeah.
Yeah, it's.
I just got back. I finally got on the line.
Oh, okay. Oh my God, I didn't know you were gone, John.
Okay, so 87 female with enlarging sternal mass. So we see this, kind of soft tissue density projecting off the sternum. The sternum itself, I'm wondering if there's actually some lucency in the radiograph. Okay, so now on CT, so on CT it's fairly sclerotic. It looks like there might be a break in the cortex, and there's this pretty large soft tissue mass just kind of surrounding and engulfing the sternum, causing some mass effect on the anterior mediastinum structures. So I would want a biopsy.
And so this was a neuroendocrine small cell carcinoma. So yeah, again, I think not very many cases where we can reliably talk, as I said before, histology. I think it's when you see lesions like this that they have to be, you have to get tissue.
I might just think that's like a bone source if I just saw that. maybe, so you wouldn't know focus.
Right, right. Ashu.
But John, that was probably diagnosed by chemistry.
It may well have been. I don't know. Ashu?
So a 16-year-old male presents with bump in the left arm. We're looking at the left biceps by ultrasound. I guess there is something just deep to the biceps. Looks like it's pretty vascular. Okay, and we can see like a pretty prominent lytic lesion involving the cortex of the humeral diaphysis. Okay, and then on the MRs, we see that it has pretty low T1 signal and pretty high T2 signal. Almost looks cystic there. It looks like it's broken through the cortex.
Yeah.
Though.
My guess is if it were cystic, it looks like there's some structure to this particular lesion. And on the T1 weighted images, it's not really low. So my guess it's going to be a solid lesion, but it certainly does look like it has a lot of water content.
Why would it be cystic, Leonard?
Well, here it's kind of low in signal, but it's a little bit brighter than the muscle. It could be a complex cyst, but most cysts are going to be darker than muscle in a T1 weighted image. But it looks very uniform in signal intensity on the stir, but this isn't properly windowed either. So we might get more structure in it if we windowed it differently. Okay. So they thought it was EG, and what this turned out to be was a cortical schwannoma of the bone.
Do you really see EGs protrude outside the cortex?
Generally not, but that's what was thought there. Yeah. And if you go back, again, this can have the signal intensity. Typically with schwannomas, you'd get a little bit of low, smudgy, low signal in the center of it. But again, this looks like it's a not terribly aggressive lesion, but it did break through the cortex.
Would you say it's kind of dirty looking?
Yeah, a little dirty looking. Okay, so let's go into the category of miscellaneous tumors here.
World of leg pain and mass. So we see this kind of extensive lesion involving the mid tibia. It looks like it's broken through the cortex on the sagittal images, which is predominantly PD bright anteriorly, and there's expansion of the bone and cortical thinning, kind of heterogeneous, multi-septated appearance.
So what's the differential in a kid? Lesions in the tibia.
The lesions of tibia, I think it's a little more proximally, but adenoma is one you have to think of in the tibia.
So that would be very aggressive. That's the most aggressive of the lesions. What are the others?
You can have things like fibrous dysplasia, and I guess you could still have things like Ewing's in the.
Yeah, Ewing's is a different appearance.
Yeah, this can be a little more aggressive.
And osteofibrous dysplasia.
Yeah.
EG and infection.
Yeah, EG infection are always, I guess, included.
But this one looks very aggressive. It looks like it's broken through the.
So I'd be worried about adenoma.
And for the aggressive lesions, it's really between osseous fibrous dysplasia and adamantinoma. Adamantinoma tend to be larger lesions when they're initially detected. That's because it's just more aggressive. You get more moth-eaten appearances, more destructions, and much more complete muscle marrow space involvement.
Do you mind going over like the difference between osteofibrous dysplasia and fibrous dysplasia? It's just more aggressive, or?
Yeah, it's just more aggressive for them. And the main reason that people differentiate him with imaging is fibrous dysplasia typically looks very benign, and most people just call it a benign lesion. And fibrous dysplasia and it's in kind of typical locations. This isn't the most common location for fibrous dysplasia, but it's not an uncommon location. Osteofibrous dysplasia is probably a different pathology. It's more aggressive. It looks much more like it's malignant. And then the Adenoma is a low-grade malignant lesion. So the treatment is different for the three, and that's another reason why they basically define them as three different entities.
Okay. Thank you.
Yeah, the treatment for the Adenoma is much more aggressive than it would be for osseous fibrous dysplasia, and the histology is different. Okay, Ashu.
All right, so 61-year-old female, left lower leg pain for 2 months. Looking at the lateral aspect of the proximal tibia, mostly the metaphysis. It looks like there's a really dense sclerotic lesion there. Looks like it's very hot on the PET, SUV 29. And I think it is bright on the thallium as well.
Right. Okay. Here's the MR.
The MR, it's pretty heterogeneous on the T2 imaging. It looks like soft tissue. I think there's disruption of the cortex on the axials, but I'm not quite sure. Looks like there's quite a bit of disruption there, anteriorly and posteriorly.
I need to see that. This looks a lot like what the osteosarcomas we saw earlier with all this hypertrophic bone formation. This is metastatic adenocarcinoma.
Okay.
And here we can see multiple lesions in the spine, typical of metastatic disease. Now, in metastatic disease, I think John alluded to this earlier. I have a better discussion of this in the lumbar spine section, but there are a couple of things to look for to try to differentiate between kind of benign and malignant lesions. And one of the most valuable is the posterior bowing of the cortex sign here. This is almost pathognomonic of malignant involvement. Most other diseases that affect the vertebral body, you'll get kind of collapse of the vertebral body, like in compression fractures, but the posterior cortex will stay a little bit concave rather than convex like we're seeing here. With tumors, you get slow destruction of the bone that weakens the cortical and trabecular bone, and then the pressure on it allows bowing of the posterior cortex. Where in other conditions, such as compression fractures, you'll fracture the trabecular bone here, but the posterior cortex is still pretty tough, and so you will not get the bowing back here. So this is very valuable. And then there are some other signs, some diffusion-weighted imaging can be helpful sometimes, and the contrast enhancement can be mildly helpful, and then obviously the history. Okay, let's now look at kind of miscellaneous lesions. What do you think of this one, Michael?
Painful limited range of motion, or painful and limited range of motion of the left hip for several years. So yeah, on plain film we see this lesion involving that posterior acetabulum ischium, and then on MRI we see this kind of expansile lesion within the posterior acetabulum, which is kind of multiseptated. It's predominantly bright on fluid sensitive sequences. On post contrast images, it's got like peripheral enhancement of those kind of cystic with fluid levels. And so we've already kind of learned, just because you have fluid levels, so it can be a lot of things. I guess it could be, again, another aneurysmal bone cyst. It doesn't look as aggressive, but you used to say telangiectasia osteosarcoma was what you always thought of when back in the past.
Yeah, you tend not to get as much bone expansion with that.
Yeah, and it'd be just more destructive.
So this is aneurysmal bone cyst. And there are many different tumors that can be associated with aneurysmal bone cyst. Aneurysmal bone cyst is probably not a real lesion itself. It's probably a secondary bony reaction to some underlying pathology, of which you don't always make a diagnosis. But this patient had chondroblastoma underlying it in this location. So there are a lot of other abnormalities that can be associated with aneurysmal bone cyst kind of appearance, eosinophilic granuloma, brown tumor, fibrosarcoma. Basically, a lot of pathologies in the bone can end up having a bony reaction that presents as an aneurysmal bone cyst. Okay. Here's this case. This is 1901, and we can see that there's this little bit of subcortical cyst here below the tibial spines, right in that location. The patient came back almost 2 years later, and it was much larger. And this is a subcortical cyst. It's very benign. This wasn't a growing malignancy. It just shows that these subchondral cysts can grow, but you know they can because you see them in degenerative disease all the time, and you see them at different sizes. So they can start out and grow. These are most likely due to strain injury, which fractures the trabecular bone. Over time, the bone tries to heal, but if you continue to have strain on that trabecular bone, you'll get more resorptive change rather than osteoblastic change, and then these can grow over time. And in degenerative disease, you get subchondral injury due to the loss of articular cartilage, and that can continue to cause microfracture of the trabecular bone and enlargement of these subchondral and subcortical cysts.
There's probably laxity in this knee in terms of stability.
Yeah, good.
And probably it's like chondral defects that we see.
Okay. Yeah. Okay. Ashu?
Okay, so here the abnormality is within the patella. This is a 35-year-old female. We can see that there's I guess a mixed kind of lytic lesion. I think there is a dense sclerotic border around it. It seems well bounded by the cortex. I don't think it breaks any cortical. I don't see a soft tissue mass, and it doesn't seem to show up on the bone scan, I don't think. Here we see in the MRI it's slightly expansile. There are multiple fluid levels. Yeah, I mean, it actually looks like this one actually looks pretty cystic to me because it is dark on the T1s, pretty dark, homogeneous on the T2s, but it does have some. Okay, so it is a cyst. Okay.
So this should turn out to be a simple cyst, and not really an aneurysmal bone cyst, but a simple bone cyst.
What would you do with that?
Is it causing any symptoms?
What would you do with this condition?
Well, I'm guessing they came in because of pain. I mean, wouldn't they be at risk for increased fracture? I don't. You could just pack it, right? You could curettage it and pack it.
Yes, you can, but the best treatment I found, and I've done quite a few of these, is anesthetize real well because they're painful when you insert a needle in them. Very painful. And inject, after you aspirate, inject cortisone. It sometimes takes more than one injection, but cortisone is very, very helpful with this condition.
Thanks.
That's the best treatment. Curettage and so on can it's number one surgical procedure, which is not pleasant, and number two, they recur more often than with a cortisone. So it's kind of like an inflammatory condition, but exactly what causes it, I'm not sure.
Thank you.
Thanks. I'll be right back.
That's a 24-year-old male, fatigue at leg for 1 month. So on a radiograph, we see this large lytic lesion in the proximal tibia with expansion and kind of sclerotic borders, and I'm wondering if this kind of breaks, the cortex looks pretty thinned. So on MRI, we see this heterogeneous expansile lesion, which is expanding and kind of protruding through the cortex. The adjacent musculature on the sides we see look normal though. Like I don't see any definite extension into the muscles. And that's pretty, and it's not fluid. It's T1, it's same density as muscle, and it's too dirty on the fluid sensitive sequences, and there's a little bit, I think that's post contrast, I assume, on the bottom right. A little bit of the enhancement.
It is expansile, isn't it?
Yeah, it's expansile. So 24.
So just look at the plain film. So
at 24. Well, and I'd be worried if there's some sort of first thing would be to say you need to rule out malignancy, but I guess like fibrous dysplasia is another thing. Non-ossifying fibroma.
That's what they thought of frozen section. This turned out to be fibrous dysplasia. And again,
Could it be giant cell tumor also?
Yeah, I think it could be, but
It's not enough close to the epiphysis, but nevertheless, I think I've seen one or two in this region.
it's possible. Generally, giant cell tumors don't have this thick.
That's the only thing. There's no sclerosis. Giant tumors don't have sclerosis that I remember.
Yeah. Shoot.
So a 12-year-old with leg pain, you see a multiseptated heterogeneous expansile lesion here. I think there's some cystic components inferiorly, and it's involving the metadiaphysis. There's areas of sclerosis on the radiograph. So I guess, again, a pretty wide differential, but
what are the lesions we think about in the tibia?
At tibia, we think about adamantinoma. We think about fibrous dysplasia. We think about osteofibrous dysplasia. We think about. Okay.
So this is osteofibrous dysplasia, and but you have to think about all of those. And this one, the main one you'd have to evaluate for is the adamantinoma, because that's the one that would be most severe. There are a lot of other lesions it could be, but those and it's a little bit too large for eosinophilic granuloma, and for having a large lesion like that for infection, you'd probably have a lot of symptoms. So, okay. And the three big here are the three big ones that we've been talking about in the tibia. Through all this stuff. Differentiation. Okay. Michael.
A radiograph of the pelvis, we have numerous lytic kind of expansile lesions throughout the bilateral femurs, causing bony remodeling and abnormal appearance, and throughout the right entire right pelvic bone, and looks like the right sacrum as well. And then it looks like we have some expansile lesion in the distal tibia as well. So I'm worried about like a congenital thing, like a something with multiple areas of fibrous dysplasia, like McCune Albright or something.
This is fibrous dysplasia.
Oh yeah, the shepherd.
And this is just the histology, showing all the fibrous lesions. Here are some other examples. This is osteofibrous dysplasia, a little bit more aggressive, a little bit different histology. And then here we can see marked deformity, and this was an adamantinoma. Much more irregular cells here. Okay. Ashley, what do you think of this case?
Is this a 9-month-old male with right proximal humeral mass. It's pretty aggressive. It looks pretty heterogeneous on T2. I think there's some cortical breaks. It looks like it crosses the growth plate. First thing I think about is infection.
Okay, good.
It's going into the soft tissues as well. You can think of, I guess, like EG, or that'd be atypical, or Langerhans. Okay, Langerhans cell histiocytosis. Okay.
More aggressive EG in this particular patient. Good. So yeah, in these cases you need to think about infection first, because you want to make sure that it's not an infection, because that could be acutely life-threatening. And then you need to make the diagnosis of histiocytosis.
If this was infection, it'd be a pretty sick kid.
Right, exactly.
Editorial: female diabetes, hypertension, shoulder pain and low back pain, paresthesia below both knees, aggravated at nighttime, hyperlipidemia. Okay, so on radiograph, she's got pretty marked sclerosis of the metaphyses, a sparing of the epiphyses of the distal tibias, or distal femurs, proximal tibias, and they're markedly hot on bone scan. So what? It's symmetric, so it's something. I'm assuming it's metabolic.
So some sort of a systemic disease.
Yeah.
This happens to be Chester disease, which is a lipid granulomatosis.
I remember learning this for boards, and I promptly forgot it.
You went into the right category. That's what's important. Good. Ashu.
So this is a 29-year-old male. We're looking at the proximal femur here and the acetabulum, and there's just scattered areas of lucency which correspond to multiseptated cystic change, and it's kind of peppered there. There's a fracture of the femoral neck there. I think it's a pathologic fracture, and then there's a second lesion there, and this is this bright? It doesn't seem. Oh, doesn't seem. I guess it does. It is kind of bright all over.
Acetabulum is involved too, isn't it?
Yeah, it was. I think on the previous one there were some changes there as well, and it seems to involve all the bones. And I mean, it's kind of scattered. I'd be worried about some type of like an infiltrative marrow process, but I don't know. It seems to involve just scattered areas of rib. Okay, so brown tumor. Okay.
Yeah, it's all from a parathyroid adenoma.
What would you do for the brown tumor?
If you treat the parathyroid, does it do?
No, you call an endocrinologist.
Right.
Yeah.
And then the next thing you do is have a surgeon and a radiologist get together, an orthopod and a radiologist, and then fix the bone that's getting so thin that you have to prevent fractures. So you fix it before it breaks, because sometimes it'll break before you can get to it. You don't want that, so you can prevent the fractures by
too late.
pre-fracture surgery.
Here's a fracture right here. We're a little too late on this one.
Yeah.
Yeah, it's already broke.
So 18-year-old female, 3 years post lung transplant, cystic fibrosis. Status post treatment for multifocal osteomyelitis, 6 months. So we just have radiographs of these like marked thickening and erythema of the fingers bilaterally. And now they have, so the pelvis, there's a lot of heterotopic bone formation surrounding the femurs, acetabulum bilaterally. So is this that like, and then they've got a, heterotopic ossification surrounding the fingers, and that's just like pulmonary hyperostosis.
Right. That's a very good thought. This happens to be a drug reaction.
Oh. Okay.
So that
Like hypertrophic.
hypertrophic pulmonary osteoarthropathy could look a lot like this as well. But this is a drug reaction.
Does the treatment cause some of this, John?
Yeah, this is the treatment that the drug reaction to the.
Oh, yeah, okay. I'm sorry. I didn't know what.
Yeah.
Okay.
And let's look at a few miscellaneous joint lesions here. Ashi, what do you think of this one?
So looking at the T1 post and FETSA T1 post, we can see large joint effusion within to thick. I think it's pretty thin enhancement there on the post-contrast imaging. I want to see it. Oh, I guess it's kind of thick medially, yeah, and thin on the lateral aspect. I'd like to see a T2 image. Oh, okay. So this is just synovial chondromatosis. You can see multiple loose bodies there.
Good. Yeah. Okay, so we've gone through a lot of different bone tumors, kind of through the WHO classification. So thank you guys. And then tomorrow, I'll have to decide what we'll start tomorrow. I don't know if we should. Do you want to go to soft tissue masses, or would you like to go back to joints?
Either one, as far as I'm concerned, John. I'd like to tell you that